wonderful episode here, Jaws Podiatry. We presented a case last week, a young gentleman who presented with excruciating pain to the back of the heel. The patient was diagnosed with a Haglund's syndrome, also known as an insertional Achilles tendinosis, not tendonitis. Some people use that word interchangeably. Tendonitis, tendinosis. Patient, how long have you had this problem for?
It's been at least a couple of years.
Years. Not months, years. So when it's something acute, itis, tendonitis, plantar fasciitis, right? Itis, osis, long-term, chronic. This is something that he's been battling for years. Let's go to the whiteboard. We'll say this is the side view. This is the calcaneus heel bone. Tendon. Achilles tendon. So he has, right, and these are all attachments here. In this area here, he has a significant amount of pain. Tendinosis. Degeneration. He also has a Haglund's deformity, which, just to exaggerate, right, he's got a really prominent, what we call a tuberosity, tuber, right? It's kind of like that. And this is rubbing against the Achilles tendon, creating fire, pain, excruciating pain, sad. It's really painful. The pain is affecting his daily life activities. He's a chef, very well-known chef here in Miami. It's affecting his work. He's on his feet. What we proposed, because of the chronic stage, years that this has been going on, I recommended we do a percutaneous microtenotomy, also known as what we like to call a deep dry needling. Okay, the needling, when I talk about needling, it's not the needling that other specialties do, it's very superficial. It's deep to the tissue, into the tendon. Okay, so there's a big difference. So we're gonna go ahead and let's roll here now. Achilles, I've demarcated everything for everyone. The Achilles rolls like that. The calcaneus is here, and I extended the size like that because that's exactly how it inserts into the calcaneus. That's how it attaches. It's in a fan-shaped manner. And as everyone can see, this is where it's a little bit even puffy. Obviously, he's got no pain here. That's we numbed everything from here up. So if everything from here down is numb. So the first part of the procedure is, like, as everyone knows, we're going to go ahead and do the, again, so, I think he had a little bit of discomfort there, but all we're doing, if you have any discomfort, please let me know. Okay? I can actually feel this area here. I can feel the tendon. You okay up there, bud?
Yeah.
Any discomfort?
No.
Go ahead and take the opportunity
A
little. When we do these procedures, the anesthesia works really well, but for whatever reason, there's a lot of cutaneous nerves everywhere. Sometimes it's the anesthesia. And I can already hear that celery-like. We're literally, and he do you feel that?
Just that one pinch then.
Okay, no, but do you feel the celery-like a little bit?
No.
So we're actually just fenestrating. Even Wesley heard that. If you put your finger here, you may feel it actually. Okay, so that's the first part of the procedure. One more. I know that all this area here is just... So why did we just do that? Right? We are creating trauma on purpose. Well, why would you do that, Dr. Wagner? Do these procedures. The anesthesia works really well, but for whatever reason, there's a lot of cutaneous nerves everywhere. Sometimes it's the anesthesia. And I can already hear that celery-like. We're literally, and do you feel that?
Just that one pinch then.
Okay, no, but do you feel the celery-like a little bit?
No.
So we're actually just fenestrating. Even Wesley heard that. If you put your finger here, you may feel it actually. Okay, so that's the first part of the procedure. One more. I know that all this area here is just... So why did we just do that? Right? We are creating trauma on purpose. Well, why would you do that, Dr. Wagner? He already has inflammation. Why would we want to do that? It's because we're essentially tricking the brain into believing there's a new injury. So not only are we, in a controlled fashion, of course, using a needle. The brain doesn't know the difference if it's a needle, a book, a hammer. The only thing it knows is that it's trauma. Interesting, right? So now what we're going to do is, that's the first part of the procedure. Not only that, once we do this, the body is going to bomb rush this area with an unbelievable amount of blood. It's going to bring the entire anti-inflammatory cascade. It's going to bring all these other important cells. And now, we're going to go ahead and infiltrate about 3 and change of PRP out of about 30 cc's of the patient's blood, which we have isolated. I always tell the patient, you may feel a little bit of pressure, discomfort. Let me know if you do, okay? Mm-hmm. So we'll go ahead and start from here. And we're going to aim for this side first. Here we go, okay, bud? Mm-hmm. And everyone may see blanching, which means that this is going to turn white here a little bit because I'm not pushing it yet. We're going very, very slow. I want to start slow. You okay?
A little push on it.
Okay. Pain?
A little bit.
Tolerable?
Yeah.
You can say stop, by the way. You hear what I said?
Yeah.
It may start to throb.
Yeah, it's throbbing now.
It's throbbing now, so I'm going to stop now, okay? We're going to stop now. It's going to go away. The throbbing will go away. Okay? It's going to continue for about 5 minutes, that throbbing, okay?
It hurts.
It hurt. I totally get, I understand. How you doing?
It hurts.
But on this side only, right?
Yeah, the bottom there.
On the bottom there. That's the area where I think the area was not really totally completely anesthetized.
It hurts.
On here or over here?
The bottom there's a burning and it hurts.
Okay. We're going to just end it right with a little bit of spritz right here.
Oh.
And we're done. It's going to throb for about 7-8 minutes. It's a very dull, achy, deep pain.
Yeah.
Okay, it's going to continue. Would you like a little bit of water?
No.
Okay. Okay, so just to recap, you guys can hear the patient. He's uncomfortable. One of my mentors always said, you cannot mix live, cells with anesthetic, which is not living, obviously. If you mix them or get close to each other, you're going to essentially lyse, or you will, I hate to say the word kill, but you're, okay? It's going to continue for about 5 minutes, that throbbing, okay?
It hurts.
It hurt. I totally get, I understand. How you doing?
It hurts.
But on this side only, right?
Yeah, on the bottom there.
On the bottom there. That's the area where I think the area was not really totally completely anesthetized.
It hurts.
On here or over here?
The bottom there's a burn and it hurts.
Okay. We're going to just end it right with a little bit of spritz right here.
Oh.
And we're done. It's going to throb for about 7-8 minutes. It's a very dull, achy, deep pain.
Yeah.
Okay, it's going to continue. Would you like a little bit of water?
No.
Okay. Okay, so just to recap, you guys can hear the patient. He's uncomfortable. One of my mentors always said, you cannot mix live, cells with anesthetic, which is not living, obviously. If you mix them or get close to each other, you're going to essentially lyse, or you will, I hate to say the word kill, but you're going to kill those living cells, and that's, not what we want to do in a case as such. We want them, that's why we try to anesthetize all the way up here, as far away from the affected area. This is the easy part. The patient, in respect to this condition, Achilles tendonitis, not even the chronic stage, there are very few treatments that we can implement that truly work. Heel pain is extremely difficult to treat. Why? Because we don't walk on our hands, we walk on our feet. You go to a physician, they may say, well, listen, we're going to put a pair of heel lifts, we're going to try some orthotics, we're going to try this, we're going to try that, try maybe, a little physical therapy, a little ice, a little anti-inflammatory, and so on and so forth. Those are the Band-Aids. We've spoken about the Band-Aids before. We're not in the business of the Band-Aids. We're in the business to help people, right? We want to help people in the long term, not short term. That's not our business. Our business is to get everyone back to their daily life activities, back to what they love to do, whether it's sports, whether it's doing this, whether it's exercise, whether it's just to stay healthy. So, this particular patient is a chef, always on his feet. Just imagine this for years. So, this is a great opportunity for us to make this better. Again, we're very limited in respect to, you guys can all see here the blanching. This is what I mean, the blanching. And he had a little bit of blanching here and it went away already. But the pain should be getting a little bit better by now. I know I'm talking a lot on this one, but I want everyone out there to know that Achilles tendinosis, anything related to that, you need to be aggressive in respect to treatment. Because just when you think it's getting better, oh yeah, it's getting better, it's going to be fine. All of a sudden, it's like this. You think it's getting better, but it's not going to get better. I promise you. It's just that vicious cycle. It's like you fall into that hamster, you fall into that hamster wheel. It's really, really difficult to get off. And that's a problem. You need to be aggressive in a good way, not in a bad way. These procedures that we perform, they work well. We've done thousands of these procedures, right? And the proof is always in the pudding. I won't talk anymore. Like always, www.jawspodiatry.com, Instagram, Dr. Tojan, Jaws Healthcare, that's our YouTube channel, Facebook, Jaws Podiatry. I'm going to post this case. This is a great, great case. You guys have no idea how many people suffer from posterior heel pain. And the patient can tell you guys, this will make, and I've seen a lot of professional players, no names, it will make any big guy suffer. Am I right?
Yes.
People limping, they're looking for solutions, not Band-Aids. Solutions, long-term solutions. This is passion. I'm not upset, I promise.